Welcome back to Takacs McGinnis Elder Care Law Hour, where we explore the many issues that arise due to aging, chronic conditions, unexpected illness, and disability. I'm your host or co-host, Tim Takacs, and today we are discussing the different types of dementias, the differences among them, and the options available after diagnosis.
And I'm your co-host, Barbara McGinnis. We've all heard of physical therapy that you receive after an injury or surgery, perhaps. But have you ever heard of neurorehabilitation? Well, you will today. Today we have Dr. Michael Riesthal. He's the Associate Professor of Hearing and Speech Sciences at Vanderbilt University and is the Director at the Pi Beta Phi Rehabilitation Institute at Bill Wilkerson. That is quite a title, quite a mouthful. I had to read most of it. But tell us, welcome, thank you for being here, and tell us what is neurorehabilitation and how does it help people with dementia?
Well, first of all, thank you for having me. Neurorehabilitation is a rehab process where the focus is on maximizing the individual with the neurological conditions functional ability for as long as possible. When we're looking at functional ability, we're talking about physical function like balance, gait, things of that nature. We're also talking about cognitive function like attention, memory, executive functions, as well as communication, how well the individual can communicate with their family and friends for as long as possible. There are a number of professions that are involved in neurorehabilitation. I know we've heard from a neurologist as well as a neuropsychologist who are important members of the neuro rehab team. In addition to that, there are physical therapists, occupational therapists, speech language pathologists, social workers who are involved in neurorehabilitation. And their focus is identifying the individual's specific needs to function within their home, within their community, and within their vocation, if they're still working, so that they can maximize their level of function for as long as possible.
So it's a special training that you get to do this?
You know, in each profession, there is training that's received in their graduate programs through academic coursework, as well as through clinical placements. Then individuals who really have an interest in neuro rehab typically will seek out jobs in those areas, and there's a lot of on-the-job training that occurs. There are specific certifications that can be achieved. For example, we have a neuroclinical specialist residency position at Vanderbilt, along with our colleagues at Belmont University, where we train physical therapists for a year to become experts in neurorehabilitation. In physical therapy and occupational therapy, there are also certifications like neurodevelopmental treatment, or NDT, as an example. And there are some certifications that are specific to certain populations. For example, individuals with Parkinson's disease may receive treatment from a speech language pathologist who has Lee Silverman voice treatment training. Or conversely, individuals with a physical therapist may have LSVT big training, which is the physical therapy side. And occupational therapists can also have that type of training.
So what about these different treatment modalities for dementias? Like, do you need to know the type of dementia to figure out which rehab is going to be best for them?
Yes. You know, it's interesting hearing the neurologist and neuropsychologist speak. It's very important early on to get the right diagnosis, right? And to know where the individual is breaking down cognitively as well as physically. And so having a specific diagnosis is important because it gives us an idea as to where they may be breaking down in terms of cognition. What we do is a pretty thorough evaluation on the speech language pathology side, OT and PT side. And we're trying to identify again, where are they breaking down physically in terms of function as well as cognitively and communicatively. And then what's most important is identifying what their functional needs are within their environment. Okay, you could have two individuals who present with the same type of dementia, but whose living situations are different. They may not have the same level of support at home. Because of that, our focus might change. We might have to make certain adaptations to rehab for one versus the other.
So tell us a little bit about the Lee Silverman Voice Therapy Program for Parkinson's.
Sure. So individuals with Parkinson's may present with dementia, but in addition, they have physical limitations as well. Physically in terms of their gait or their walking, their balance, but also in terms of communication. With regard to communication, they often will present with what we call a dysarthria, which is a motor speech disorder. In particular, they have a hypokinetic dysarthria. And there's a treatment that's been designed for that called LSVT loud. And the focus of that treatment is on getting the individual to be loud. Individuals with Parkinson's disease may present with reduced volume. They may have short rushes of speech. They'll make articulatory errors. And this, the group that designed LSVT loud found that by simply focusing on volume, getting the individual to be loud, to think loud, they were able to increase volume, but they were also able to reduce the number of articulatory errors they make so they can be more intelligible and communicate more effectively with their friends and family.
Yeah. We have a client recently that was in the Parkinson's, and she, very soft spoken,
Yes.
hard to hear, and then the mumbly, garbled. So
Yes.
it was all very challenging, and she's very patient with us and trying to understand her. But there's communication problems with dementia as well.
Yes.
So how do we deal with that?
So when looking at the type of dementia, we also want to look at, again, where they're breaking down in terms of communication. Oftentimes individuals have difficulty with naming or word recall, right? So they may know what something is, but they have trouble remembering the name of it. They may know who someone is, but they have difficulty remembering that person's name, right? What we do is kind of look at how that issue is impacting their everyday life. We can do a variety of things. I should say that neurorehabilitation can be restorative in nature, meaning we're trying to boost systems back to close to baseline as possible, but also compensatory. And oftentimes with working with someone with dementia, it's a balance between do they have the ability to have some restorative therapy, or is it compensatory? With communication, we're often looking down the line to see what this person's going to need. We might start developing augmentative and alternative communication avenues for the individual, which can also help with their cognition. So augmentative and alternative communication means that it's anything that enhances spoken communication or takes the place of it. It could be as simple as writing things down, which would be kind of alternative to speaking, but by writing something down, it may actually help the individual be able to speak more clearly because they have a list of things that they may want to discuss. They may organize their language a little better. We also use pictures. We might create a communication book for an individual who has these types of communication issues, and it has pictures that may be broken down into different categories: breakfast, for foods, breakfast, lunch, dinner, locations where they like to go shopping, family members, places they'd like to visit in the community, so that if there's a communication breakdown, there's something else that one can go to. The big thing in looking at communication and cognition and physical function in individuals with dementia is always trying to be one step ahead.
I was going to say is let's get these patients started early.
Yes.
Right.
Anticipate.
And so as their dementia progresses, then they've got options.
Yes, and that's a great point. The earlier, the better. You know, if you can identify these issues early on, you can start thinking about how can we address it now, but then thinking, okay, should this progress, and it often does, what is this individual going to need? And we want to be at least one step ahead. And oftentimes we want to train things that they may need to use in the future before they actually need them, so that as they continue to progress, we can transition to that new system when it's necessary.
Yeah.
All right, I think we're going to put your contact information up in just a moment. Is there any takeaway for us, for our audience?
I think the takeaway would be to, if you're identifying that there are signs and symptoms that might be dementia, talking to your primary care physician, getting in to see a neurologist. Certainly neuropsychological evaluation is important, but then getting in early to start rehabilitation.
Right. All right, so here's your contact information. We're talking with Dr. Michael de Riesthal of the Beta Phi Rehabilitation Institute at the Vanderbilt Bill Wilkerson Center. Thanks for sharing your information with us, Doctor.
Thank you.
Up next, we are talking about local resources with Alzheimer's Tennessee. Don't go away.